Dear Chairman, dear colleagues, I am very honored to be here, and I thank the organizing committee for giving me the opportunity to share with you this talk dealing with COVID-19, cognitive disorders, delirium, and encefalopathy. I have no conflicts of interest to declare. So the question of major neurological damage, such as encephalopathy or coma, arose very quickly in the face of the COVID-19. The first publication reporting this concern was that of Mao, published in JAMA Neurology in March 2020, indicating a prevalence of 36% of neurological forms with consciousness disorders in 15% of patients. Since researchers from all over the world have not ceased to study these neurological disorders. Numerous works have been published of a variable typology, sometimes prospective using large cohorts, but sometimes and often retrospective and in the form of reported cases. The prevalence of neurological impairments has been reported varying from one study to another, depending on the type of population studied, but also according to the involved world area. Thus, the denominator could be the severity of the overall presentation, intensive care management of patients with or without neurological expertise. The prevalence could thus vary widely from 3 to 80% of cases. Overall, the prevalence is fairly consistent with the initial description. It is about 30% of hospitalized patients, all forms of severity included. The pathophysiological mechanisms involved in neurological damage are based on two theories. The first one is that of neuroinvasion, which may involve the olfactory nerve, the nociceptive innervation of the nasal cavity by the trigeminal nerve, or the innervation of the vagus nerve located in the respiratory tract or in the gastrointestinal tract. The invasion progresses to the circumventricular organs, allowing easy access to the blood-brain barrier and induce an inappropriate immune response. The second theory, not necessarily contradictory to the first one, is that of endothelitis, where the virus would be responsible for lesion of the blood-brain barrier, either by systemic pathway or by neuroinvasion, as we have just saw. This results in a cytokine storm on endothelial damage with microthrombi responsible for hypercoagulation state, microglia activation, hyperexcitability, and hypoxic lesions, leading to the neurological symptoms of the disease. These different injuries will vary over time. First of all, they are acute damages, which can occur particularly in critically ill patients. Neurological damages such as cognitive disorders have also been described in the context of persistent post-acute sequela, which may involve a chronic phase. Finally, even later sequela could be observed, as in other respiratory viruses with neurological tropism. The little experience we have at present with this disease does not allow us to rule out the late complications that may occur. There is a wide spectrum of neurological signs that have been reported, often overlapping with a corresponding diagnosis. These signs range from minor symptoms such as anosmia to life-threatening events. In hospitalized patients with neurological damage, the clinical or functional signs are dominated by arousal troubles such as encephalopathy or coma. Headaches and anosmia are frequent. The corresponding diagnoses and syndromes are reached, again dominated by encephalopathy, which can take several etiological forms to which we will return. Strokes are the second most common cause of major neurological manifestations in patients with neurological disorders requiring hospitalization. Neuropathy and seizure are not rare. Encephalitis or Guillain-Barré syndrome have been less frequently reported. Now let's focus on this study dealing with encephalopathy, which is the most frequent syndromic form. It can be related to different causes. In a large number of patients with or without neurological involvement, Frontera's team reported encephalopathy in 12% of cases. This could be related to septic or hypoxic ischemic in nearly 60% of cases each, or uremic injury in about 30% of cases. Associated forms were frequent in this study. If we now look at an even larger population of patients, hospitalized or not, whose data were obtained from coding, the overall prevalence of encephalopathy is much lower, about 3% of cases. Also, this information is not available here. It can be assumed that the encephalopathy concerned a large majority of patients requiring ICU management. It is interesting to note that encephalopathy was reported predominantly in patients with stroke, but also with isolated peripheral nerve or plexus involvement, probably reflecting the systemic involvement of the disease. These different disorders can be grouped in a syndromic manner according to the physiopathological mechanisms mentioned at the beginning of this presentation. Thus, the injuries may be direct or indirect. When they are direct, they can rarely be responsible for encephalitis by a neuroinvasion mechanism. They can much more be frequently associated with endothelitis, responsible for local ischemic or hemorrhagic complications, CNS vasculitis, or even posterior reversible encephalopathy syndrome. When the damages are indirect, they can be grouped in metabolic encephalopathies, we have already talked about, coagulopathies, such as stroke, central venous thrombophlebitis, or intracerebral hemorrhage, including subarachnoid hemorrhage, but also dysregulation of the immune response, and finally, also in iatrogenic complications. The data we are now looking at confirms that the temporality of these different disorders is indeed acute or subacute, occurring overall within a median time frame varying from 2 to 13 days after the first signs of a COVID disease. A longer delay of the magnitude of 18 to 20 days is noted for Guillain-Barré syndrome. Finally, the median delay between the first neurological manifestations and hospitalization was negative, indicating a greater occurrence of neurological damage before hospital management. The identified risk factors associated with the occurrence of neurological damage were studied in 2 studies reporting concordant results. Thus, in these studies, an older age, male gender, and the existence of comorbidities, especially neurological ones, are independently associated with these manifestations. The occurrence of delirium in the ICU is a very particular form of encephalopathy that have been very frequently experienced by every one of us as responsible for management difficulties. In a large retrospective study involving 69 intensive care units all over the world, Poon and al. Reported delirium in 55% of patients, occurring within a median time of 12 days after the first symptoms. By multivariate analysis, fewer delirium and coma-free days were independently predicted by younger age at admission, female gender, no history of smoking or alcohol abuse, and by the absence of invasive mechanical ventilation or absence of the use of vasopressors on day one of management. Similarly, as we have seen that the prevalence varied according to the typology of the patient studied, the mortality of those with neurological damage is variable, around 18% overall, but ranging from 2 to 86% of cases, underlying the great variability of available data. If we now try to distinguish mortality according to the presence or absence of encefalopathy at first time of management, we see that the trend is the same in all these studies, where encephalopathy is associated with lower mortality, with the exception of SHU studies, which involves a large number of critically ill patients. Finally, only 2 studies looked for an association between different demographic and initial management variables on mortality. It can be seen here that in each of these 2 studies, the intensity of consciousness disorders ranging from encephalopathy to coma was independently associated with hospital mortality. Now, let's have a look at persistent post-acute sequelae. In this meta-analysis, including more than 250,000 of patients, 55% demonstrated having at least one sequela at short, intermediate, and long term after COVID-19 diagnosis or hospital discharge. The most frequent sequela concerned global functioning, respiratory, psychiatric, and neurological impairments. General functioning was altered in 44% of cases, and 38% of patients experienced fatigue or muscle weaknesses. Importantly, psychiatric disorders were reported in nearly 30% of patients and implicated sleep disorders in 27% of cases, depression in 20%, and post-traumatic stress disorders in 13% of cases. Neurological sequelae implicated difficulty concentrating in 24% of cases, memory deficits in 19% of cases, and finally, cognitive impairments in 7% of cases. Physical impairment improved from 1 to 6 and 12 months from 60 to 20% of cases. Cognitive impairments also improved over time from 26 to 16% of cases. Contrarily, mental health impairments demonstrated higher rates at long-term evaluation, significantly higher than those of matched control. All of these impairments resulted to a decreased quality of life scores at 3 months in all domains, significantly higher than those of matched control. Interestingly, mental health impairment at 6 months were higher in patients that demonstrated encephalopathy during their hospital stay. This difference was observed for all mental health domains and particularly marked regarding mood and anxiety disorders. Let's finish with the rare vaccine-related complications. Vaccine-induced immune thrombocytopenia and thrombosis is a new syndrome that was mainly reported in recipients of adenovirus-based COVID-19 vaccines. This syndrome is caused by antibodies to platelet factor 4 that activate platelets and cause thrombosis in the absence of heparin, similar to spontaneous heparin-induced thrombocytopenia. Its prevalence is rare, reported from 1 to 4 cases per 100,000 of patients using the AstraZeneca vaccine. The syndrome can be considered as definite, probable, possible, or unlikely. In its definite form, it requires the presence of all 5 of the following criteria. The first one is onset of symptoms ranging from 5 to 30 days after vaccination against SARS-CoV-2. The second one is presence of thrombosis. The third one is thrombocytopenia with a platelet count below 150,000 per cubic millimeter. The fourth one is D-dimer level over 4,000. And the last one is positive anti-PF4 antibodies on ELISA. In this syndrome, clinical manifestations are dominated by neurological complications such as cerebral venous sinus thrombosis, intracranial hemorrhage, and ischemic stroke that can cause encephalopathy, coma, and ultimately cognitive disorders. Finally, the associated mortality rate is globally of 22%. And predictors of death in this syndrome are baseline platelet counts and the absence of intracranial hemorrhage. To conclude, I would say that encephalopathy and cognitive impairments represent a major part of the neurological symptoms encountered in SARS-CoV-2 infection, apart from minor symptoms such as anosmia or headaches. These manifestations are associated with major pathologies mainly indirectly related to the infection, such as septic or even hypoxic ischemic encephalopathy, stroke, or intracerebral hemorrhage, but also can be rarely directly related to the virus, such as in encephalitis. All stages of management can be affected by these damages, from the acute phase to persistent post-acute sequela, chronic, or even after vaccination. And the severity of encephalopathy and consciousness impairment is independently associated with outcome and corresponds to an hospital mortality rate nearly of 80% of cases. Thank you for your attention.